Alright guys, let's get busy talking about chromosomal disorders, specifically disorders of the sex chromosomes. We're going to be largely talking about Klinefelter syndrome and Turner syndrome. I want to give you guys an overview of how we're going to approach this topic. So first we're going to be talking about the molecular genetics, which I'm circling these little circles here. These are how I represent my gametes. So we're going to be talking about gamete production and non-disjunction. And then we're going to talk about how these non-disjunction events lead to a phenotype that is going to affect our gamete producers, aka our testes and our ovaries. So that's going to be the next part. We talk about the pathophysiology of errors in our testes and ovaries. And finally, we're going to talk about how this affects presentation. So we're going to talk about all the classic presentation signs of both Klinefelters and Turners. So let's start off by talking about Klinefelter syndrome. And in Klinefelter syndrome, our genotype is going to be 47XXY. So we're going to have 2 copies of the X chromosome and 1 copy of the Y chromosome. And this is going to be due to meiotic non-disjunction errors. This is going to happen in advanced paternal age, but it can also happen on the maternal side. So let's go ahead and zoom in here and talk about the molecular genetics. These are representing gamete formation. So here I like to represent my males as orange. You guys know I like to do that. And I like to represent my female phenotype as green. And let's remember that our males are going to have an XY genotype and our females are going to have an XX genotype. Now, in normal production of gametes on the male side, we're going to have sperm that undergo meiosis 1 and meiosis 2, making some sperm that carry an X and some sperm that carry a Y. On the side of the eggs, all we have is X's. So after meiosis 1 and meiosis 2, we have X's in all of our eggs. Now, normally these are going to create pairs of either XX or XY in our zygote. However, let's talk about what happens in non-disjunction events related to the male. So we have our normal XY male, and then after meiosis 1 and meiosis 2, we can have non-disjunction events. So we can get some sperm that are carrying both an X and a Y, and some sperm that are carrying nothing. These are going to go on to pair with normal eggs that both carry an X. And so what we're going to have is an egg and a sperm union here that is going to produce an XXY zygote. So that is what happens when we have male non-disjunction. Let's move on to talk about what happens when we have female non-disjunction. So in females, we normally are XX, and they undergo meiosis 1 and meiosis 2 to make gametes, and some eggs are going to carry 2 X's and some are going to carry nothing. This occurs with non-disjunction. In our male side, we're going to represent what happens normally. So we're going to have some sperm with X and some sperm with Y. In the instance of Klinefelters, we are going to have the joining of an XX egg with a Y sperm, and this is going to create an XXY zygote. So these are the 2 ways in which we can get a genotypic Klinefelters patient, and let's talk about what happens when we have our XXY. So in terms of our XXY genotype, in terms of phenotype, this is going to cause testicular dysgenesis, which is going to present as seminiferous tubule fibrosis as well as Leydig cell dysfunction. Now, I want to insert a term here that's really important. This is going to be hypergonadotropic hypogonadism. So we talked about how we're getting hypogonadism here because our testes are not developing properly. So let's go ahead and take a look at how this affects hormonal axes by zooming in here. So we talked about the fact that we have hypogonadism. So our testes are not operating appropriately. So we have reduced function in our Leydig cells and reduced function in our Sertoli cells. And this is going to cause decreases in the activity of our Leydig and Sertoli cells. So we're going to have decreases in testosterone as well as decreases in inhibin. And I'm going to draw here an imaginary pituitary gland because this is going to be important in terms of feedback. So the pituitary gland usually is going to receive negative feedback from production of testosterone and production of inhibin from the structures in the testes. The pituitary gland is responsible for producing FSH, which is going to give agonism to Sertoli cells, and then it also produces LH, which is going to give agonism to our Leydig cells. So in the case of testicular dysfunction, our pituitary gland is going to be releasing a lot of LH and a lot of FSH on our Sertoli cells and our Leydig cells because it's not getting that necessary feedback that it's used to from these cell populations. So if we look here, we're going to have this hypergonadotropic effect. So we're going to have really big levels of LH and really big levels of FSH because the pituitary is really trying to ramp up activity in the testes, but the testes can't keep up because they're dysfunctional at baseline. So to wrap out our pathophysiology, we talked about the fact that we have decreased inactivity of Sertoli cells. This is going to reduce the levels of inhibin, and therefore we're not going to get the necessary feedback. So we're going to get increased levels of FSH from the pituitary, which is that hypergonadotropic effect. We see the same thing on the side of Leydig cells. We're going to have decreased testosterone, which is going to cause increase in LH because we're not getting that testosterone feedback to the pituitary. And then also we're going to have Leydig cell hyperplasia because they are under constant exposure to the luteinizing hormone from the pituitary. However, they are still not functional. So they're growing, but they're just not making any testosterone. In terms of our presentation here with our non-functional testes, we're going to have infertility due to azoospermia. So there's not enough testosterone levels, and we have fibrosis in our seminiferous tubules. So it's going to be very difficult for these males to produce enough sperm and proper sperm in order to carry out reproduction. Additionally, we're going to have gynecomastia, and this is going to be due to increased levels of estrogen. And these increased levels of estrogen are not necessarily a huge increase, but we know that we have decreased levels of testosterone. So relative to testosterone, we have much higher levels of estrogen. And so these testosterone levels, which are low, cannot offset the estrogen. So the estrogen is going to take over, and it's going to cause this gynecomastia because there is no testosterone to fight against our estrogen. Additionally, we're going to see an increase in height, and this is due to SHOX genes. And SHOX genes are going to be found on our X chromosomes, and we know we have an excess of X chromosomes here, so we have double the amount of SHOX genes, and so our patients are going to be really tall due to overexpression of these SHOX genes. Additionally, we're going to see testicular atrophy, and this was our main cause of all of our symptoms in the first place because we can't produce testosterone and we're having difficulties in our Leydig cells and our Sertoli cells. In order to clinch this diagnosis, we're going to go ahead and get a karyotype that would show XXY genotype. However, in order to get that karyotype, we would be pointed out to the fact that someone has Klinefelter syndrome due to things like our breast development as small testicular size, wide hips, which is a feminization due to that imbalance of estrogen and testosterone. You can also see narrow shoulders and like poor body hair growth, few chest hairs, etc., etc. Additionally, these patients can have mild developmental or intellectual delays, so they may struggle in school, and that's another way to point out that someone has Klinefelter's. And then usually it's going to be when these patients present with infertility and they're worked up for infertility that they discover that this patient has Klinefelter's. If we were to biopsy these atrophied testicles, we would see that the seminiferous tubules have fibrosis and we have Leydig cell hyperplasia. Remember that hyperplasia is occurring because we have that hypergonadotrophic effect from the anterior pituitary that is trying to spur the Leydig cells on to make more testosterone, but they're faulty. So they're getting bigger, but they're just not making testosterone appropriately. Some important associations to know about Klinefelter syndrome are going to be an increased risk of testicular cancer, as well as an increased risk of breast cancer. And this is going to be due to the imbalance of testosterone and estrogen in the male body. And these patients can also get mitral valve prolapse. I like to remember this because they have that tall, really lengthy structure. And to me, that's going to also occur in their heart, and they're going to get a prolapsing mitral valve. Let's move on to talk about our Turner syndrome, which is going to be our genotype of 45X0. Let's talk about some of the molecular genetics. So this is going to be due to errors in paternal meionic non-disjunction or mitotic non-disjunction after fertilization, which is referred to as mosaicism. So let's review some of this content. I like to denote my paternal stuff in orange. So we know that our paternal gamete formation is going to start as XY, and then after meiosis 1 and 2, we're going to normally have an X and a Y. However, what happens in Turner syndrome is we're going to get one that is XY and one that is 0, and this one that is 0 is going to go on to match up with an egg that is carrying an X. So we have this 0 and we have the X, and together this is going to make an X0 genotype. Now, another interesting way it can happen post-fertilization. So this brown cell represents a post-fertilization zygote, and it is going to have an XX genotype. However, in early mitosis events, we can get a cell that fails to get an X chromosome. And so what happens is we have some cells that are X0 and some cells that are normal XX. And this is called mosaicism. So depending on how early on in the mitotic divisions this mosaicism happens can dictate how severe the Turner syndrome is going to be. So when it comes to the pathophysiology of our Turner syndrome, it's going to be all about structures called streak ovaries. And very similar to what we were talking about in Klinefelter's, streak ovaries are kind of rudimentary ovaries. They're not doing their job very well. So let's take a closer look at our diagram again, and I'm going to use technology, and I'm just going to circle what we talked about previously with Klinefelter's and kind of transpose it over here onto our discussion about the female structures. So if you remember in our Klinefelter, we had poorly functioning testes. In our Turner syndrome, we have poorly functioning ovaries. And so our theca cells and our granulosa cells are not going to be doing their job. So we're going to get poor feedback of estrogen and androgens to our anterior pituitary. Therefore, our anterior pituitary is going to be like, hey, you guys need to like really step it up into gear. So it's going to produce a lot of LH and a lot of FSH. And so that's the hypergonadotropic effect here, but we're dealing with hypogonadism because the gonads just don't work. So we're pumping FSH and LH onto these gonads that just are not able to respond. And that's what we get with this classic hypergonadotropic hypogonadism. And since we know our ovaries are responsible for producing estrogen, we're going to get primary amenorrhea because we do not have significant estrogen in order to carry out a menstrual cycle. Additionally, we're going to have short stature here, and this is related to the SHOX genes, which we were talking about on the X chromosome. So we know that SHOX is responsible for height, and it exists on the X chromosome. So if you only have one copy as opposed to two, you're not going to get the level of height you need, and this is why Turner syndrome patients usually have a short stature. Additionally, you're going to see a webbed neck and a shield-like chest. So if we look down here, we'll see that this patient has like a webbed neck and this really broad, wide chest. This is going to be a classic high-yield description of a patient with Turner syndrome, and it's going to jump off the page at you, and it's going to help you get questions right. In terms of our diagnosis, this is going to be clinched with a karyotype that is going to show X0 in terms of our genotype. And then in terms of labs, we talked about this hypergonadotropic, so increased FSH and LH, and then hypogonadism, so failure to produce significant levels of estrogen. Turner syndrome is also associated with some pretty high yield things on test day. So in terms of cardiac stuff that can happen in our Turner syndrome patients, they can have a bicuspid aortic valve, and they can also have coarctation of the aorta, which is going to show up as a 3 sign on chest x-ray. So the 3 sign here you can see is this here, which I'm outlining here, and this is what it looks like when we have coarctation of the aorta right here. It gives us this little sign on chest x-ray that looks like a 3, so that's something to be on the lookout for. We can also have lymphatic obstruction, and this is going to lead to things like lymphedema or cystic hygromas, and cystic hygromas are when we get collections of lymph here along the neck as we have obstruction of lymph return to the thoracic duct. So I just want to highlight those for you, cystic hygroma and lymphedema. And then in terms of renal abnormalities, we can see horseshoe kidneys in these patients as well. Now you may be asking, okay, Jake, so this person doesn't have ovaries that are working very well. Are they able to have a baby? Because likely their uterus is just intact because there's nothing wrong with the uterus that you've mentioned. And you're absolutely right. The uterus is actually okay. However, due to the fact that these patients have faulty ovaries, they have trouble getting pregnant, but it can be done. So through IVF and hormone supplementation, it is occasionally possible for Turner syndrome to carry pregnancies. So that's something to be aware of on test day. Let's wrap up by talking about a slightly more simple pathology called 47XYY. And this is going to be pretty simple on test day. This is just an extra Y chromosome. It's going to present with tall stature and a little bit of a motor or language delay, but there's going to be no fertility issues here. So I kind of like to think of this as Klinefelters. They're going to be tall. They might have a little bit of a language or an intellectual delay. However, they're going to have no issue with fertility. So this is largely not going to have a lot of management. It just might be something that slips in on test day, but likely you're going to get asked about Klinefelters and Turners more often. So let's go ahead and do a high yield review. Remember that Klinefelters is going to do to XXY. This is usually going to present in a vignette as a lengthy, tall male who comes in who cannot get pregnant with his partner, and you're going to do a karyotype, and it's going to show up as XXY, and you're going to have to explain something about a non-disjunction event or associated findings in terms of lab values. Remember, key here is the fact that we have lab values that display hypergonadotropic hypogonadism, so we're going to have high levels of LH and FSH from the pituitary, but we're not able to produce significant levels of testosterone testosterone in response due to the fact that we have non-functioning Leydig and Sertoli cells. Wrapping up Turner syndrome, we're also going to have this hypergonadotropic hypogonadism, so our labs are going to be the same: increased FSH, increased LH, decreased estrogen, and this is going to lead to high yield findings like webbed neck and shield chest, and also a short stature, and we talked about this being due to absence of one X chromosome, leading to less SHOX genes being present. So these are the things to look out for in terms of high yield chromosome disorders on the exam. Hope you guys enjoyed this video. See you in the next one.